Good afternoon, everyone. Welcome. Community program planning process led by our very own Angela Brand.
My pronouns are she, her. I am the director of the CARE TA Center. Today's session is on the community program planning process. So we'll talk a little bit about the MHSA and the CPP. And then what we'll also do is take a little bit of time to go through some of the feedback that we've collected, meeting with folks in various spaces, primarily county staff, talking about where you're at with your CPP. Some of the information that you've all shared with us through listening sessions, meetings that we've had, and other engagements where this topic has come up. And then we'll talk through some of those challenges that seem to be kind of woven throughout your experiences and offer some recommendations that have come from you all, as well as some of our partners when thinking about how to do community engagement work. I know that some of you were probably at the session that we recently hosted at the beginning of the month, where we did a really deep dive into the community program planning process, really tried to unpack all of the different pieces. And I think, before we get started, I just really want to elevate some of the conversation that we've already had here today, with Debbie's presentation on the evolution of the MHSA and how much change has happened over time. How many things have happened, within the last 18 years since the MHSA has, been a part of the behavioral health landscape. Really thinking about, Erin from Fresno County shared a comment earlier today about the collaborative nature of this work and how it's really great to be able to come together and talk about this work, but recognizing that it is often challenging because there isn't a one-size-fits-all approach to how we do this work. I also want to name as well the complexity of talking about MHSA as a funding source. I've heard it referred to as the rebar of the behavioral health field. It's really just kind of woven in throughout. And so it can be really difficult to kind of pull apart the components and really look at how do we do this type of program or this type of service with MHSA when there's so many other, components woven in. And so thinking about the reflections, and we'll talk about it in just a little bit when we talk about the listening sessions and the engagement that we've done with many of you around this topic. But really just, again, gratitude for those that show up and continue to share what your experiences have been like, asking questions, really being there to support one another, offering, information on how you might be doing your process, how you might be doing certain components of your community engagement work, and just really thinking about how we can take that and use that to help strengthen as we go through with this. So I am going to move to the next slide. And so when we talk about the MHSA, and as I've said before, the third year of this project has really been, a strong redirect back toward the Mental Health Services Act. The funding, how it's used, providing support to counties, in their MHSA programming. And in doing that, we've really come to you all with a lot of different webinars and virtual learning events where we've, talked about MHSA, kind of in a way that we recognize, as I said, the complexity of it as a funding stream. And there's just so many small, nuanced pieces. And so thinking about that, a lot of the information that we present on, that we talk about, anything pertaining to the MHSA, this is kind of our reference slide. So a lot of that information is, pulled directly from the Mental Health Services Act, Welfare and Institutions Code, or WIC, as it's sometimes referred to, the California Code of Regulations, or CCR, and then information notices that are supplied by state agencies, primarily the Department of Healthcare Services, that outline any changes to the MHSA or those codified policies. So what is the Mental Health Services Act? Some of these slides we'll go through a little bit quicker. because we've already kind of touched on what they are, but it's Proposition 63, now known as the Mental Health Services Act. It is the 1% tax on personal income over $1 million, sometimes referred to as the millionaire tax. As Debbie went through her slides earlier, we talked about, the intent of the MHSA to be transformational in terms of provision of mental health services in California. And one of the things that she really emphasized was that community engagement component, which we'll talk about here in just a moment. But the MHSA is structured under the 5 components that you see listed on your screen: community services and supports, prevention and early intervention, capital, facilities and technological needs, workforce education and training, as well as innovation. And I will say, there's a ton of acronyms in this presentation. I will try to make sure that we name those as we go through. There is a resource document that is posted in Socio under the materials link that's an acronym list that I would encourage folks to grab as a guide, not just for this presentation, but for some of the presentations that we have tomorrow, to kind of help folks that might be newer to this space get through the acronym soup that often accompanies most of our presentations. So the MHSA is organized under the general standards that are here. These standards are what guides implementation, development, and delivery of programs and services. They're listed here: community collaboration, cultural competence, client-driven, family-driven, wellness, recovery, and resilience-focused, and integrated service experience. We're going to focus primarily on the community collaboration piece, although the rest of the standards are embedded within the community program planning process. It's the community collaboration piece that really guides this part of the planning. Under the MHSA, every county is required to develop a 3-year plan, a 3-year program and expenditure plan, or an annual update. These plans outline all of the programmatic and budgetary planning for the county for each component, those 5 components that I just listed before. The annual plan, the annual update is the annual update to the 3-year plan, and that's completed for the 2nd and 3rd fiscal year of the plan period. And it outlines all changes to the plan, including expenditures. All of these expenditures do have to be consistent with an approved plan or annual update. In the event that there's changes within, the counties are able to submit additional updates outside of those 2 spaces. So the plan, like I said, outlines all of the programmatic and related expenditures for each component. And to note that within that, it also includes county demographics, including but not limited to the size of the county, threshold languages, unique characteristics, age, gender, race, and ethnicity. And then it has to include programs by component. And those programs have to be consistent with guidance that's provided in code and include the numbers served in each age group and the cost per person served. Plans also include information on the prudent reserve. There's an expenditure plan, the stakeholder process, which is bolded here. We'll get into that in just a moment. Performance outcomes, the county compliance certification, the fiscal accountability certification, information on the Board of Supervisors adoption, and then a note here that the annual update should include a description of changes that are made to the 3-year plan. So a description of any new programming and the rationale for added programs, changed programs, or discontinued programs. So what's included in the plan and update relative to the stakeholder process? So as a note, just there's so much documentation, the need for documentation and reporting and checking this box and checking that box. And so, the maintaining of documentation and timelines, is consistent with the requirements for the state around the plan and annual update, as well as program review, which is conducted by the state. And so the documentation relative to the stakeholder process includes information on a description of the local process. So that's meetings, planning activities, anything done that brings folks together for the purpose of community program planning. a description of the stakeholder process, a description of meaningful stakeholder involvement that's consistent with Welfare and Institutions Code. The term meaningful stakeholder involvement isn't something that's well defined. And so just naming that here, that can be, a phrase that means a lot of things to a lot of different people. A description of training that's provided to the participants, including information that's relevant to new or revised projects. The dates of the 30-day review process, which we'll talk about in just a moment. The methods that are used by the county to circulate for the purposes of getting public comment on the draft of their plan or annual update. Strategies and activities that are designed to elicit public comment of the drafts. The date of the public hearing that is held by the local mental health board or commission. And then a description, summary, and analysis of any substantive changes, recommendations received during the 30-day public comment period and the county's resulting actions, including any changes made to the plan or update in response to those public comments. So it's a lot of information, a lot of listed requirements as outlined in Welfare Institutions Code and California Code of Regulations. And this is just that list. And so thinking about that, it's a lot. If there are any questions, again, I just want folks to be able to put that into the chat. If you'd like, you can turn on your microphone. This can be a very interactive conversation. I realize it's a lot of information. It's not particularly exciting and it's pretty heavy on code and regulation. So wanting to be able to support as we go through all of this. In alignment with the community collaboration general standard, counties partner with local community members as part of their stakeholder process. This stakeholder process is a requirement of the MHSA to develop 3-year plans and annual updates, and it's a process known as the community program planning process. This is where you identify, or where in partnership with local stakeholders, identify community issues relating to mental illness resulting from a lack of community services and supports, including any issues that are identified during the implementation of the Mental Health Services Act. Thinking about and analyzing the mental health needs of the community. So again, looking at the landscape of your individual community, the demographics, those residing within, and thinking about the specific needs of those populations within the community. And then identifying and evaluating priorities and strategies that are needed to meet those needs. So in that, those services and programs, ensuring that they're culturally competent, relative, and responsive, they're client and family driven, they are recovery focused, and they are integrated. So again, back to the standards that we previously reviewed, embedding all of these pieces within the programming. The stakeholder process can look different in every county, as many of you already know. The CPP is, an overall term for a structured process that the county will use in partnership with local stakeholders. This is a conversation about how to meet the needs in the community, looking at populations, looking at folks that are at risk or have, historically been underserved, and thinking about how to develop responsive programs in response to that need. And those engagement opportunities can look different from county to county, as I said, but they can include a lot of different things like you see here. So stakeholder engagement and outreach through things like an MHSA planning council, a steering committee, a cultural competence committee. There can be general community meetings or community forums. I've heard from a lot of folks that they do population specific, as well as broader community meetings, thinking about how to engage with specific groups or underserved populations that don't often come out for, government community meetings. Other ways of engaging with folks might be through focus groups, surveys, key informant interviews, listserv announcements, social media engagement, all just different ways to be responsive to communities, to meet them where they're at. The process also includes MHSA and CCP or CPP training. This is both for staff that work at county behavioral health departments, as well as for stakeholders and local community members. And then the process not concludes, but the process wraps up with the final piece, which is the 30-day public posting and comment period, followed by a public hearing, and then the Board of Supervisors approval. And key partners in this process include community members, stakeholders, families, clients, youth, county behavioral health departments, local behavioral health boards and commissions, Board of Supervisors, and then ultimately the state. So both the Department of Healthcare Services and the Mental Health Services Oversight and Accountability Commission. Just another, nod to what we talked about earlier, that the counties must demonstrate meaningful stakeholder involvement. And so the Welfare Institutions Code does outline a definition of local stakeholders. That includes adults and seniors with severe mental illness, family members, caregivers of children and youth, or family members, caregivers of adults and seniors, providers, including those that are providing substance use disorder services, law enforcement, including probation, those that are in education, social services, veterans serving agencies, and representatives of veterans organizations, those working in healthcare services, and then you have other important groups such as the LGBTQIA+ populations, youth, and transition age youth. The California Code further unpacks that to ensure that representatives of unserved and/or underserved populations are included, and that stakeholders should reflect the diversity of the county demographics, so geographic location, age, gender, race, ethnicity, including clients with serious mental illness and/or serious emotional disturbance and their family members. So it's a pretty wide group of folks. But again, just naming that the meaningful is a term that, is often brought up in these conversations as being subjective. And we'll get into it in just a little bit. Some of the feedback we've also heard is, how many people, what does it look like to really fulfill the intention of meaningful? The draft plans and updates are to be posted for local review during a 30-day comment period. So once the county's gone through their community program planning process, they've taken in all the information and they've put together this 3-year plan, or they've updated their 3-year plan through their annual update, those plans go up for a 30-day public review period. These plans are to be made available to community stakeholders and any interested party who has requested a copy of this plan. During this time, the counties will work with their local mental health board or commission to schedule a public hearing on the draft plan. These meetings can be online or in person or hybrid, and they are scheduled to occur at the close of the 30-day review period. The goal of this hearing is for the folks, members of the public, to provide recommendations, feedback, any proposed revisions to the draft plan. After the hearing, MHSA staff will then take everything back, review the public comments received at the hearing, and respond to questions or comments in writing. These questions and comments are to be included in the final plan or update, and are defined as feedback that would affect or require a programmatic or fiscal change in that plan. After all of that, the county adopts the final plan and update, incorporating all of those public comments and feedback. They submit to the Board of Supervisors, who then approves or adopts the final plan or update. And then that final plan or update is submitted to the Department of Healthcare Services and the Mental Health Services Oversight Accountability Commission within 30 days. So to support all of this, because it takes a lot of work to ensure that all of these pieces of the process are covered, counties do have, and it's at the bottom of the slide, but counties have up to 5% of their total annual MHSA funds that can be set aside for community program planning. There's also a requirement that staffing is provided. So it says that the process should be adequately staffed. Again, there isn't an official definition of adequately staffed, but the county shall have positions within their departments that are responsible for their CPP, including the coordination and management of the process, and stakeholder outreach and engagement efforts. The training that we recommend, or that I mentioned just a moment ago, so there's training that's provided to staff to help them understand and uphold the functions required in code. And there's also training that should be made available to stakeholders about the MHSA, its components, and the requirements of the CPP. If this is in the materials, you can find this on Socio, and we can share out. I'll see if I can find the standalone graphic to share out with folks as well. But this is the recommended timeline for the development of the annual or the 3-year plans and annual updates. And so it starts at the beginning with the annual revenue and expenditure report that's due to the Department of Healthcare Services. That's due in January. DHCS provides feedback. That's where this starts. Like I said, I apologize. This is really tiny writing, and I know that most of us probably can't see it. But if you look right between June and July is when there's information about the 3-year program plans, the annual updates, and the community program planning process. And so I've included this slide because it provides information on what the recommended timeline should be. And in doing that, I know that not every county has this exact timeline, in their space. And so thinking about this, thinking about, what we had talked about in a previous session, really looking at, hearing from folks where they feel they are in this timeline, how closely aligned counties feel to this timeline, and then thinking about future plans relative to the work that the CARE TA Center is doing, and just generally as a technical support provider, what kind of supports and information would be needed to help counties align with this timeline. It's here written out. Again, that writing on the other side was really small. So, January and February are when the counties submit their annual MHSA revenue and expenditure report. Sometimes it's referred to as an ARER or an RER. This goes to the Department of Healthcare Services and the Mental Health Services Oversight and Accountability Commission at the end of January. This is when counties should start to begin their community planning process. So any type of community engagement, community forums, local meetings, that's the recommended timeline for this to begin. Through February and March is when, as that information is coming in and those plans are being developed, counties are starting to put together the initial part of the plan while also continuing with their community program planning. So, so that it's lined up for, somewhere within March, April, and May for those plans and updates to be posted for the 30-day public comment period. And then at the end of that, the hearing that we talked about happening between June and July, the completed plans or annual updates would then be approved, and counties would move into the new fiscal year. And so that's when they would submit their fully approved plan to the DHCS and to the OAC. And I see a few things coming in on the chat, so I want to be mindful of that. And so I'm going to take a pause just a sec to check these questions. So the first one came in about if there are requirements for how they advertise for stakeholders. There's not specific requirements in terms of, this many, radio advertisements or this many, things have to go out in CPP. I'm sorry, listserv or email or social media. I know that there's some counties that do a lot of really broad communication, but I also recognize that certain methods of communication are more likely to reach certain populations. So newspaper ads or radio might be more effective for certain populations than others. So this is a good time. We can hop into our part 2 of the presentation, which is it's a review of the listening session data. And when I say listening sessions, we did a primary listening session at the end of last year, and we had folks from Kern, Santa Barbara, Ventura, Calaveras, Tulare, Monterey, and Amador County We've also been able to collect some feedback in subsequent meetings. So working with the MHSA coordinators through CBHDA. And then we did some polling in our initial overview of the MHSA virtual learning session in January. And so we used a lot of these as opportunities to just sort of check in. And we talked a little bit in Debbie's session about how the redirection of the Care TA Center project, back toward the roots of MHSA, we've spent a little bit of time this year. I'm not sure what the phrase I'm trying to think of is, but really just, kind of coming back to you all on a regular basis to say, how's it going? What do you need? What does this look like for you? What kind of supports can we provide through our project to better support the work that you're doing relative to MHSA, which was a little bit different than what we did in the first couple of years of this project. And so, we've had a lot of opportunities to ask questions, even in the session today, recognizing, the complexity of this work. And, there's so many details and there's a lot of guidance, but thinking about what we've said before, every county is a little bit different and, everyone has some autonomy to develop their plans, that work best for them. But knowing that, and I think Tracy, you just said, the staffing turnover, that's a really big concern and that impacts the ability, for all of you to be able to have consistency in this work. And so some of the feedback that we received, let's see if it's here. So we talked a lot about, where folks are at. What's the current process? Are folks back in person? Are they, staying online? Is this, hybrid space? Importantly, what's the post-pandemic impact on engagement look like? What types of outreach methods and strategies are you all using to bring people in? So to the earlier question, is there a certain number? Do we have to do outreach in a certain kind of way? Talking about what those methods and strategies look like. Thinking about barriers for community participation, which, even pre-COVID has been, a question that's asked in the community program planning space. Going to the heart of, the development of these plans is driven by consumers and family members and community members. How are they involved in developing or implementing these programs or interventions? Asking about success stories, or the challenges that you're facing and maybe looking at opportunities for supports and training through that. And then shared strategies for inter-county learning, so just kind of what we're talking about here. And then, how to wrap it up with needed tools and supports so that, through either the Care TA Center or, CalMesa with their guidance, what does it look like for there to be a place where there can be tools and supports that will help all of you sort of, adopt or replicate some of these more, successful or, helpful methods. And so, what we heard around community engagement is, how to develop the content, how to, write for your audience so that it's not political or jargony or clinical, thinking about how to explain the MHSA process, the funding, sort of that landscape, how to do that in a way that it is easily digestible for the audience that it's designed for. What does meeting structure look like? A lot of folks shared that these post-pandemic shifts have resulted in lower participation rates from community members. It's difficult, right? Because we went virtual, which gave online access to folks who maybe physically had difficulty in getting to community meetings. So this virtual space opened up a great opportunity for them to be able to participate fully in the process that they, previously hadn't been to. But then we also heard from a lot of folks that the virtual space wasn't something that worked well for certain populations. For example, we had someone share that they really saw a drop off in promotorious involvement in their process when things switched to the Zoom platform. We had a lot of folks share that there were significant drops in participation from youth, those in tribal communities, as well as the AAPI population and older adults. And then in terms of other structural components, there was a lot of questions around finding a good location. Where are folks meeting that is accessible, that has access to public transportation, that isn't a county or government building? And how are you all working through the budgeting so that you can do things like pay for food and childcare? How are folks providing incentives for participants? And then this point here, straight to the question that we got at the beginning of the session, is what is meaningful engagement? Are there target numbers to reach? And then naming specific requirements, like, is there a certain number of stakeholders that should be involved? Are there a certain number or types of locations that should be included in the process? How do you know if you're offering everything, in the right languages to meet the needs for your particular community? We talked a lot about surveys. And so some of the information that was shared was, how do you develop your survey to ensure everyone's voice is heard and required information can be collected? Some of the feedback related to that was, not everybody's going to fill out an online survey. If you have a survey, and there's another point here, if you have a survey, how do you make sure that it's translated properly in all the languages that are needed? How do you do it in a way that is widely accessible? Kind of to the community engagement slide before, so that your language isn't too jargony or too political or too muddled with requirements and welfare institutions codes embedded within there. And so, we had questions about the number of questions that folks use. How many questions is too many? How many is enough to get the information that's required while still being able to get, good qualitative information from folks? Are folks using infographics or anything to kind of help, provide that training so that as folks are taking those surveys that they know, what they're being asked and why? And then how to take that post-survey reporting and communicate that out. We talked about data and information collection, examples of how the data can be reported in creative and culturally responsive ways, how data is reconciled and that information is collected, and then how that information is then put into programming, or sometimes not put into programming. We had a lot of conversation around what to do when folks come to the table with a need and an idea or a program that should be developed, and the county's not in a position to be able to do it right then and there. And then how is that communication managed? I think that that's something that's been heard for quite a long time. At the beginning of our session, back in the beginning of April, we talked about how there's been a lot of spaces to highlight concerns and challenges with the community program planning process, largely from stakeholders. There were a lot of efforts done through some of the Oversight and Accountability Commission's stakeholder contracts to talk about the CPP and the challenges that folks were experiencing with working with their counties. And I really wanted to reframe that here, that I think that this is just one of a million things that is happening while programs are being developed, and that it's really important to name that there might be times where something is needed for a certain population within a county that program can't be developed at that time. And it sounds like from what we're hearing here that the struggle can be, how do we communicate out when we can't do that? Because then we hear from stakeholders that, well, yeah, we showed up, but they didn't do what we asked them to do. And so how do we in this space, hold, have those conversations so that there's support for you all in communicating that out? And that was a challenge that was shared by quite a few folks. So throughout that, we thought, what are some of the opportunities for shared learning? And to Erin's point earlier with Debbie's session, the idea that these collaborative spaces can at least increase communication between counties and county staff. And not necessarily that there'll be, an option that suits everybody or that fits everybody. We know that what is happening in Mono County will be very different than what's happening in Los Angeles or Sacramento or San Bernardino. But there are some things that we can, kind of bring together to talk about, which are, what are some of the, pitfalls to avoid when going through the CPP process? How can, those of you that have been doing this for, a long time, share your expertise and your experiences and what I wish I knew when I started this, with those staff and those teams that are, coming in, with maybe less experience under their belt. What are the processes and strategies that you're using, whether it's, engagement with a specific population, or if it's thinking about these templates that Cal Mesa's created, are you taking those and utilizing those in your county and with your teams, and what does that look like for you? Think about who's invited, what best practices are used to engage with communities effectively. So we talked a little bit a couple of years ago, there was a session and Ahmad from Fresno shared, different strategies that they use in Fresno to engage with very specific populations, down to one of the details was they brought bags of rice into the community meetings because the gift cards weren't something that, were seen as, an incentive. And so really just getting down all the way into the nuanced details of what are some of these best practices and how do we compile all of them in a way to share it out so that we can put it all on the wall. And then where you all are at as a team, you can kind of take down what you need and try to implement that on your side. And that includes things like where and how folks are hosting events, what kind of events get the largest turnout. We had someone share that they planned a large community event. They anticipated 200 people, they bought food for that whole thing, and they didn't have, that number of participants. And so, how do we forecast something like that? How to connect with the community on spreading awareness of these events. And then thinking within that, how do you communicate the safety in having an event like that? Creating a space where folks can feel safe to come, especially those that may be undocumented and going to a government building does not sound safe. How do you find a place for trans youth to come in and talk about being involved in the process in a place that's safe for them? How are you partnering with local CBOs, building trust through cultural brokers and others that are connected to the community that can provide you with trusted pathways? And then other than consultants, how are you using your funding in support of building your CPP? And so these are just some of the opportunities that we've identified for continued shared learning, things that we hope to expand on in future events and future virtual learning sessions. And then this is just some of the feedback that we heard. Ultimately, we're doing too many events. We have 20 planned and attendance at most of them is terrible. I feel like we have a good mix with stakeholders, but we're still not reaching everyone. In general, we've been so short-staffed that management has been answering front desk calls for months, and I think that shortage is reflected in our numbers. I think I have one more. Thinking about the new folks that are coming in and trying to take in all that's MHSA, navigating all of this can be really confusing. So creating a site of shared knowledge would be amazing. At a statewide level, having a consultant who could do information gathering and focus groups for counties so that the counties can focus more on actual program planning and plan writing. And then this comment stood out as well. Our whole process has shifted many times. I've been here for 6 years and we've had 3 different community planning processes during my tenure. What are some of the unique challenges that your organization or agency is facing that maybe isn't reflected on this list or hasn't yet been discussed? What are some of the more pressing challenges that you're facing right now with your CPP process? How many are in alignment with the timeline as presented? And as you're looking at that, thinking we're not there yet, what types of supports would be needed to help you and your team start to line up with that? And then what are some of the unique strategies that you're using that maybe we haven't discussed or, haven't come up on this list? These are questions that we'll continue to ask. And as we explore opportunities for continuing this project, this is something, the community planning process, community engagement, the heartbeat of the MHSA is engaging with consumers and family members. And so how do we continue to show up with supports for you all? Thinking about the comment of, having a site of shared knowledge. Just thank you to everybody for joining us today.